Hello everyone, welcome back to my channel. I'm Dr. Ushna Nubid. Today we are going to discuss a very important high yield topic for your exam, which is basically GB syndrome. Okay, Guillain-Barré syndrome or Guillain-Barré syndrome, you call it as GBS. That is a very important topic with respect to your neurology portion of your exam. There are many recalls. If you just tried solving recalls, there are a clutter of recalls in your exam. So if you want to join the full session for your theory preparation, that I offer 2 months full paid theory course, that is AMC Smart Prep platform, and this is the WhatsApp group link. You can just scan the code and you can join the group for your preparation. All the updated guidelines are available in the group. So before wasting any time, just start the GB syndrome. It's a very important topic, so you need to know everything about this about this topic. Okay, how you are going to diagnose this topic, how you are going to what are the first line investigation, what are the important investigations, what are the complications, and what are the systems that are mainly involved in the GBS. These are your main high yield concerned for your GBS discussion. So let's start. What is basically your GBS? Okay, we have some learning objectives. We are going to define the GBS. We have to understand the pathophysiology and the triggers. Although AMC not very concerned for the pathophysiology, but just for your better understanding, I have added a very short slide of pathophysiology. So to just have an idea that how the GBS is going to develop into your body and what are the basic triggers you have to look for in the MCQ. And you have to identify the clinical features, which are very important to make the diagnosis and investigation diagnostic criteria. Then you go for management and you recognize the complications. So this is a overall very high yield topic for your exam. Okay. So what is basically a GBS? What is by definition, what you mean by GBS or Guillain-Barré or Guillain-Barré syndrome? It is an acute inflammatory response that attacks your peripheral nerves. Okay, so peripheral nerve, that's why we called it as polyradiculoneuropathy. Peripheral nerves are attacked and it is always progressive. That is not that in within a days or within a night the patient is developing symptom. This is a progressive symptoms, and the patient is always having symmetrical weakness. Both legs, both arms, these are going to be affected, not the unilateral one. So symmetrical is a very important clue, progressive is a very important clue, and the third most important clue is your areflexia. This is a very high yield clue for your exam, that the areflexia with the symmetrical weakness, think of GBS. Okay, so this is your pearl, that the bilateral weakness, absent reflexes, you should think of this GBS syndrome if that weakness is preceded by any kind of recent infection. Then what is the pathophysiology? So any trigger, which is basically the most important factor, is the Campylobacter jejuni. This is the culprit organism that is causing the GBS syndrome, and due to that trigger your immune system is basically activated, and that immune system recognizes your immune cells rather than your bacteria and attacks your nerves. Okay, due to molecular mimicry, they think that your neurons are like the bacteria and they start attacking the neurons. So you are going to have demyelination of your neurons. Okay, that's why we called it as demyelinating disorder. Your sheath of your neurons is breakdown, it's broken. Okay, so you are going to have impaired nerve conduction due to that breakage of the neurons. That's why we are going to have weakness. That's why we are going to have areflexia. So this was the basic concept of pathophysiology. We are not concerned with the pathophysiology much, so we will not go into much details. Now the very important thing is, what are the trigger factors? What are the preceding factors for your GBS? The very important one, the very high yield one, is your Campylobacter jejuni. Most of the time they give you as a clue for the Campylobacter jejuni, but we can have many infections. We can have any vaccination. We can have cytomegalovirus, any mycoplasma infection, Epstein-Barr virus infection, and sometimes they love to give influenza also, because influenza is very common. You are having upper respiratory tract infection, you are having gastrointestinal infection in the form of Campylobacter jejuni, in the form of influenza, and after that you are having symmetrical weakness, so think of GBS. Okay, so all these are trigger factor for your GBS. And the very important thing is, you should be familiar with the time frame. That is very important, that what is basically your time frame for GBS. It occurs 1 to 4 weeks after the trigger. So you are going to have some infection related to your GI, related to your respiratory portion, and after 1 to 4 weeks you are going to have neurological symptoms. Okay, so after infection you are going to have neurological symptoms. That is a very important clue for your GBS. Again, GBS is a very important topic. How you're going to diagnose this condition? You should be very particular about the clinical features. First of all, the very important thing is symmetrical. This word is very, very important. I'm telling you again and again, symmetrical. Both legs, both hands are going to be affected. And you're going to have ascending paralysis. You just need to remember all the A's for the GBS, okay? All the A's together is for GBS. So what are the A's? You are going to have ascending paralysis, you are going to have areflexia, you are going to have autonomic dysfunction. These are very, very important A's for your GBS topic, okay? Due to this autonomic function, patient can have any bladder, any bowel symptoms, which can be distracting sometimes. But remember, any ascending weakness preceding the upper respiratory tract infection along with areflexia, this is your GBS until proven otherwise. The next very important thing to just focus on this topic is that if you just look at this picture, that there is progression of the respiratory failure. This is something alarming. This is something AMC loves to ask. Okay, so they ask about the complications of the GBS. That is going to be your respiratory paralysis. So we are more concerned for the respiratory paralysis rather than ascending weakness of the limbs. Okay, so this is the feared complication you should look for. Then weakness pattern is a very typical ascending. That's why the patient is going to have feet, then arms involved. The feet is it's basically ascending from the downward to the upward. So from feet to the legs to the arms, then face, and then the patient is going to have respiratory muscle weakness. So this is the end result of your disease. Now, very, very important thing is the patient can present with any symptoms, any symptom. He can have flaccid lower motor neuron type weakness. He can have difficulty walking, climbing stairs, lifting arms, swallowing, because your muscles are not able to put the weight, okay? They are becoming weak. Your legs are becoming weak. So you are not able to walk, you are not able to climb stairs, you are not able to lift the arms. This is the main presenting complaint, ascending weakness. Always symmetrical ascending weakness for your GBS syndrome. Then you can have sensory weakness as well, because the underlying process, remember, our neurons are getting damaged. Your neurons are not okay in your body. That's why you are going to have neuropathy as well. The patient can present with the paresthesia, numbness, burning pain, back pain, radicular pain. This can be your presenting feature of your GBS as well. But stick to that focused topic that you are going to have upper respiratory tract infection, and after that you are going to have these typical neurological symptoms which are causing GBS. Okay, so these can be your distractors. These are associated features, but do not stick to that features. Just focus on the main features which are defining features of your GBS syndrome. Now the very, very important thing is that there are many cranial nerves which can be involved in your as a part of your GBS weakness. Okay, this is second most important thing that they love to ask about your AMC questions, that you can have bilateral facial weakness as well. Your facial nerve can be involved. You can have bulbar weakness. The patient is not able to speak properly. Patient is not able to swallow properly, and the patient can have ophthalmoplegia as well as a part of your GBS. So these are all the presenting features. You can say these are atypical presentations of your GBS. Okay, so you have to remember all these as well as a part of your cranial nerve involvement. Very important one. And then you can have autonomic dysfunction. Patient can have sweating, patient can have pupillary changes, hypotension, sexual dysfunction, urinary retention, hypotension, all are the part of GBS. So autonomic should not distract you guys. Be focused. Upper respiratory tract infection, any diarrheal illness, after 1 to 4 weeks, the patient is going to have ascending weakness. This is your GBS. Along with this statement, anything can be there. Anything, any sensory change, any autonomic change, any cranial nerve weakness, anything can be there. Okay, so don't be distracted by the associated features. This is your GBS until proven otherwise. Now the very, very important part, which is basically your recall question most of the time, that is your respiratory failure. When you are going to have this weakness of your GBS, muscles are going to be ascending paralysis, the patient is going to have respiratory involvement. Due to diaphragm weakness, the patient can present with a dyspnea, cough, unable to count to 20, reduced vital capacity. So it's very important to monitor the vital capacity, FVC, forced vital capacity, in the patient of GBS. It will give you direct clue that the patient is having respiratory involvement or not. So mostly in MCQ they ask about the FVC. Okay, think of FVC as a part of your diagnostic workup of your GBS patients. This is very important. Respiratory thing you should not ignore. So test, we have different kind of test, but the important thing In AMC, they love to ask the particular things. They do not ask that what are the investigation you are going to do, and there will be a list of investigation. This is not how the exam comes. They are very particular. What are the initial investigation? What are the confirmatory investigation? How you are going to diagnose the GBS on clinical basis. So that's how you have to approach the questions. Initial investigation is always your lumbar puncture test. Okay, make sure this is your initial investigation. On lumbar puncture, you are going to have this typical word which is known as albuminocytological dissociation. What does this fancy word means? Albumino, you are going to have protein, okay, protein, increased protein. Cytological, you are going to have cells problem. Okay, so what happens? You are going to have increased protein and normal WBCs, or even decreased WBC sometime. So your proteins and your cells are not comparable to each other. Okay, there is dissociation of the two parameters, albuminocytological dissociation. This word is written in the MCQs most of the time. And the confirmatory is always going to be nerve conduction study. You are going to have slow conduction, you are going to have conduction block. This is the best confirmatory test we do for GBS patient. So initial is going to be your lumbar puncture test, and confirmatory is going to be your nerve conduction study. These are your two recall questions. And along with that, always consider FVC. Okay, this is again your recall question. In eMedicine, they have been discussing it so many times about the respiratory problems. So you should be very focused about your respiratory complications of your GBS syndrome. Next important thing is that sometimes they ask about the variants as well. This is not very important one, I would say, but sometimes they have asked this variant, especially this Miller-Fisher syndrome. This has come in the exam 2-3 times. Okay, so Miller-Fisher syndrome is a very important one, and the least important one is your AIDP, AMAN, and AMSEN. Just remember the names, that sometimes if they ask, you should be familiar, you should not be blank. So this is acute inflammatory demyelinating polyneuropathy. This is an acute process when the inflammation is still there. This is the most common. When we have acute motor axonal neuropathy, that is purely motor, you are not going to have any sensory component. You can have acute motor and sensory axonal neuropathy, which is a mixture of both presentations, and you can have Miller-Fisher syndrome. So what is the difference between Miller-Fisher syndrome? Remember this very particularly, because this is your recall question. Okay, they love to ask about this variant. Okay, so you should be very particular about this variant at least. Not every variant is important, but this one is important one. So in recall, they have mentioned that the patient will present with a typical triad. The patient is going to have areflexia, which was a part of your GBS syndrome. The patient is going to have ataxia, which is normally not a part of your GBS syndrome. So areflexia along with ataxia and ophthalmoplegia. This combination is there. Think of Miller-Fisher syndrome. And they ask about the antibody. So remember this antibody as well. Anti-GQ1B antibody is very particular for your GB syndrome. So these are the variants. Now in options, the most important thing, if they are asking diagnosis, we become confused with a differential diagnosis. Okay, so be particular about the differential diagnosis as well, how you are going to rule out these conditions. Myasthenia gravis also present with the weakness of the muscles. Botulism also present with the weakness of muscles. So how you are going to differentiate between the things? Myasthenia reflexes are going to be normal. Your GBS, that was having areflexia. Botulism, it's presenting with a descending paralysis. Your GBS, that was ascending paralysis. Spinal cord compression, they present with the upper motor neuronian. Your GBS, they were having lower motor neuronian. Okay, and this is also having sensory level, which is not a part of your GBS syndrome. Hypokalemia, they will mention potassium. Then this is not very important, to be honest. So these things are very important as a differential, and you should be very particular that how you have to rule out the differential. These are very important for your exam. Then how you're going to manage the patient. You have done everything, you have made the diagnosis, you have come to the conclusion, this is my GBS patient. Then how you are going to manage the patient. This is a very important thing. So first of all, you have to admit the patient. Why we have to admit? Because again and again, I'm saying there is a chance of respiratory paralysis. The patient can go into the coma. The patient can go into the respiratory failure. So you have to admit that patient to keep an eye on the respiratory parameters. You have to do FVC, you have to monitor the respiratory muscles, everything. So you have to admit the patient. Then there are certain indications which indicate ICU admission rather than the normal admission. Okay, so what are these indications in which you have to admit the patient to the ICU? This is very important again. These are the indications in which the patient is already having some kind of weakness. Respiratory weakness, bulbar symptoms, rapid progression, and severe autonomic instability. These are the indication for your ICU admission. Never ever give steroids in your GBS patient. Whenever we see inflammation, we love to give steroid, but GBS do not respond to steroid. Do not give steroid at all. Then what is the first line treatment? So first line treatment is going to be IVIG. This is the first line treatment, or you can go for plasma exchange. Both are equally effective, but we go for IVIG most of the time. And along with that, you have to go for supportive care, because we have to, you can say, prevent the complication. So this is basically your management. IVIG, don't give steroid, ICU admissions, and you have to admit the patient. You have to look an eye onto the forced vital capacity. Then comes the prognosis. We are not concerned with the prognosis much, but in older age, in mechanical ventilated patient, it has a poor prognosis. So we know that certain conditions have the poor prognosis in the old age. Sometimes mortality is so high, we are not concerned with the prognosis much for the AMC exam. Then these are the high yield pearls. These are the take home message. These are the nutshells you have to remember. And these are very beautiful pearl that is shown in the picture. So just remember, most common preceding infection is the Campylobacter jejuni, a very, very important one. You have to remember this organism. Sometimes they ask this organism as well. So this is the organism which is culprit for causing your GBS patient. Hallmark clinical feature is areflexia, which is very, very important picking point. CSF finding is going to have increased protein with the cells, that is known as albuminocytological dissociation. Confirmatory test is going to be nerve conduction study, and the first line treatment is going to be IVIG or plasma exchange. Never ever give steroids. And the most important monitoring that you have to do is forced vital capacity. Okay, this we have discussed again and again and again, that forced vital capacity is very important one. And the most feared complication is basically your respiratory failure. That's why we are going to monitor the forced vital capacity, because we have the fear of respiratory failure. So this is all you need to remember for your GBS syndrome, and that is making your life so easy, because GBS is a very high yield topic. It's going to be there in the exam. Let's practice an MCQ. A 35-year-old man, he presents with a progressive weakness of the both legs for the 5 days. So progressive word, both symmetrical, 5 days, acute history. Followed by the difficulty in climbing stairs. He had diarrhea 2 weeks ago. So we have very particular history, diarrhea, and we have duration, 1 to 4 weeks duration. On examination, there is a bilateral flaccid weakness. So we have lower motor neuron weakness, which is a flaccid weakness, absent ankle and knee reflexes, which is stating areflexia. CSF show elevated protein and normal cells. What is the most appropriate initial treatment? So remember, initial treatment always go for IVIG. Don't go for steroids, okay? Steroids is never is the treatment. We are going for IVIG as the initial treatment. We are not choosing plasma exchange, because plasma exchange is coupled with the steroid. We do not want to give steroid to the GBS patient. That's how the questions are going to come in your exam. Again, these are the same take-home message kind of thing. You can remember it as a one-liner notes, as a revision notes, whatever you say. So these are the take-home message, basically the very important one for your AMC exam. The same kind of question, let's say a 20-year-old man, he presents to emergency department following a recent conscious collapse. He reports acute onset of the blurred vision. Now remember, the presentation is somewhat different. Blurred vision, but that is followed by the legs suddenly giving away. So he's having a weakness of the legs. He's not able to put pressure on the legs. When he was walking from the kitchen to the bedroom, for the past 3 days, he is experiencing tingling sensation in the feet. So sensory component is also there. He was unwell with the upper respiratory tract infection 2 weeks ago. So typical history, from which he is fully recovered. At that time, he experienced several days of nausea and vomiting, sore throat, nasal discharge, no diarrhea. Medical history, type 1 diabetes is positive. He is having gastroparesis. Regular medication include insulin and metoclopramide. Some informations are not required to reach the diagnosis. These are just distractors, so just forget about these things. On examination, he appears well with the vital signs normal. There is bilateral facial weakness as well, with the loss of nasolabial fold, inability to lift his eyebrows. So remember, just collect all the information together. Bilateral weakness, progressive weakness, followed by the respiratory tract infection. Then he's going to have this facial weakness also. Cranial nerve involvement is also there. So all the things putting together. Power is reduced to 4/5 in both lower limbs and both upper limbs as well. There is a patchy numbness of the bilateral legs, so up to knee, and reflexes are absent. So everything is there. Areflexia is there, cranial nerve palsy is there, ascending weakness is there, and progressive nature is there. So what is the most likely diagnosis? Is it multiple sclerosis, cerebrovascular accident, diabetic polyneuropathy, GBS, or motor neuron disease. So we are very concerned about, we are making the diagnosis of GBS because we have just read the topic so thoroughly, that the patient is having ascending weakness, he's symmetrical, areflexia, bilateral facial weakness, all the part of GBS. Very, very important one, because it was preceded by the upper respiratory tract infection. So areflexia, just this is a very, very important clue. And how you're going to just key facts, these are the same repetitions again and again, that the patient is presenting with a Campylobacter jejuni, albuminocytological dissociation is very important, IVIG plasma exchange is the treatment, steroids are not effective, and you have to monitor the respiratory portion in the form of forced vital capacity. Okay, so that is all about your GBS. Hope you find it beneficial. GBS is a very high yield topic for your exam. Neurology is sometimes so confusing that you should be very, very particular, very clear about the diagnosis, about the initial, about the confirmatory test. So they are going to come in exam. So if you join the full course for your preparation, this is the Telegram link and this is the WhatsApp group link, and this is basically the barcode you can scan to join the WhatsApp group. And basically that is 2-month preparatory course, the theory session that is available with the very minimum charges, I would say. So any detail if you were like to ask, this is the number, you can just contact on this number and ask any detail about your theory preparation for the AMC 1. Okay, so best of luck for your exam. If you want me to cover any particular topic further, you can comment into the comment section and subscribe the channel to get updated with the latest videos. Thank you.